morning, everyone. I'm Dr. Sarah Mustafa from DentistChannel.Online. Welcome to today's webinar about tooth-supported overdenture, the minimal standard of care for your edentulous patient, Part 2. While we are waiting for the participants to join the session, I will introduce you to our company. DentistChannel.Online is a digital dental media company. It is your marketing solution for dental events, product launches, workshops, and courses. We also provide a collection of scientific articles and blogs about different topics in dentistry. We work hard to be your first-hand information on the technological advancements in the dental field. Now it's time to start the session about tooth-supported overdenture. If you have any question about this topic, please feel free to ask it in the question and answer box, and we will answer each and every question at the end of the session. I will start by introducing today's session speaker, Dr. Mahmoud Ramadan. Dr. Mahmoud Ramadan has completed his graduation BDS from the Faculty of Oral and Maxillofacial Surgery in MUST and post-graduation in Prosthodontics from the Faculty of Dentistry at Mansoura University. He has completed a PhD in Prosthodontics from the Faculty of Dentistry at Azhar University of Cairo. He is also a visiting professor of removable prosthodontics. Welcome, Dr. Mahmoud. It's our pleasure to have you with us.
Welcome, Dr. Sa. Welcome. We can start the lecture now?
Yes, please.
Welcome, doctors. We are now completing the second part of our interesting topics, tooth-supported overdenture. Today, we are talking with the clinical and laboratory part, the practical part. First, we are starting to talk about treatment planning. The first important topic is patient selection. We must know about our patient medical history, oral hygiene, patient complaint, motivation, chief complaint of our patient, why he wanted to have dentures. This is a very important topic. Also, abutment selection is very important topic. Position of the abutment, selection of the strategical position of the abutment is very important in overdenture making. Number of abutments also. Increasing the number of abutments increase the degree of success and increase also the value we can take from these abutment teeth. Periodontal evaluation is very important to know if the abutment teeth used for overdenture is a good candidate for overdenture or not. Endodontic evaluation is also very important. Decay or previous restoration are what we call restorative evaluation is very important also in this topic. Interarch space, as we said in the first lecture, it's very important to detect the type of attachment to be used as an overdenture attachment. So we have three major objects or options to be used as an overdenture abutment preparation. We say we can do an endodontic treatment and close it with amalgam plug. We can do a cast dowel and a dome-shaped coping like this, and we can make it more advanced and add an attachment, as we said before, and we said the all types of attachment in the first lecture. Factors to be considered here to select one of these three options. First one, the cost. As we said, to do the attachment, the patient must pay the suitable fees for making these attachments. Abutment condition also is a contributing factor also. Does the patient have high risk to caries? This is very important. If the patient have high risk to caries, it's contraindicated to make a dome-shaped preparation like this and close it only with amalgam plug. We must make a short dowel at least and a coping like this. Do we need extra retention to compensate the loss of peripheral seal from the ridge and soft tissue undercuts? This is a very important question. Do we need extra retention, or the retention of the attachment is sufficient? So we will talk about the abutment selection, how to select your abutments to be a candidate for overdenture treatment. First, the position and the number of abutments. At least 1 tooth per quadrant. This is a strategic placement, as we see here, the quadrilateral distribution. We see here a tooth per every quadrant. This is a quadrant, have a canine. This is a quadrant, have a canine. This is the right quadrant, have a premolar, and this the left posterior quadrant have a premolar also. So this is the best distribution for the overdenture abutment.
Doctor?
Yes?
Sorry for interrupting you. Are you switching slides? Because it's only one slide here. Are you switching?
Yes, I switch.
So can you try making a slideshow? Yes, now it changed.
Yes. Can you see it changing again, Dr. Sarah?
Yes, we can see the slide of position and number of abutments.
Yes.
This is the slide. Yes, try to switch to another slide to make sure that it's working.
I switch now to another slide. Is it fixed?
Yes, it's the same, didn't change. Try to do the slideshow, please.
Okay, okay. I will stop the share.
Yes,
and
now, yes, now.
I will share the full screen mode.
Yes, please.
Is it changing, Dr. Sarah?
Yes, doctor, it's better. It is changing.
Yes.
Thank you.
Okay, we continue talking about position and number of abutments. As we see here, at least 1 tooth per quadrant, as we said before. Retained teeth should be preferable not to be adjacent together, because it will predominantly compromise each other. There should be several millimeters of space between the reduced tooth form like this. We must have a space like this in order to apply the oral hygiene measures and not to cause gingival impingement between the denture base and the tooth structure, causing the sequelae we discussed in the first lecture, like gingivitis and periodontitis. Canines and premolars are the best overdenture abutments to reduce the adverse forces at these sites. These sites have the maximal biting forces for our patients, so the strategic placement of the abutments in this area will tolerate well the forces of mastication. So we have 3 best options for strategic placement of abutments. This is a quadrilateral distribution. Number B, the tripoding distribution. We have 2 canines or 2 premolars and 1 central incisor. Number C, the bilateral distribution of abutments. We may have 2 canines or 2 premolars, and this is the worst option we can make, that we make a unilateral distribution of abutments, because the patient will tend to bite only on the one side he have the teeth on. So we're going to talk about periodontal and mobility status of teeth. It is a very important issue. As we said in the contraindication, it is contraindicated to use remaining roots that or teeth that have more than grade 3 mobility. In grade 3 or more, it's contraindicated. We can use grade 1 and grade 2 And we can't use an attachment with teeth having mobility more than grade 1 mobility. Bone support is very important. So radiographic examination is very important to estimate the crown root ratio. It's a very important topic. Pocket depth is also very important. If the pocket depth increased more than 3 millimeter, periodontitis or gingivitis may be present in this abutment. Width of the attached gingiva must not decrease less than 3 millimeter. Mobility, as we said before, furcation involvement and root morphology. This all factors that we mentioned is very important to be examined on the abutment tooth before making the overdenture. So it preferred to have a minimal mobility, at least of 6 millimeter of bone support, attached gingiva around the abutments, good oral hygiene for the patient, proper emergency profile to support the marginal gingiva. Here in X-ray, we see this is the center of rotation. So the level of the bone here at the crest of the bone is very important, because this level is the level of the center of rotation and our center of support. If this center goes apical, the crown root ratio increased a lot, making a liver class 1 as we study in livers before. This is liver class 1. When the fourth arm here increased, the forces, or the effect of force increased so much, and this will lead to mobility of the abutment. Then we can lose it in the future. Then we will talk about endodontic potential and the prosthetic status. We preferred the single-rooted teeth because they are easier to treat, and the failure rates of endodontic treatment are very low for it. So it will be prolonged as an overdenture abutment. Pulpal recession is also important. If we have a pulpal recession, we can maintain the pulp vitality, and this is very important for the abutment tooth. The use of restorative material and sealant. Superior root canal treatment already done must be examined well to see if the endodontic treatment is done well, or we need to do an endodontic retreatment to make it a good candidate as an overdenture abutment. Potential for root canal treatment is also important to select the abutment or not. Then restorative condition. We must examine every abutment tooth for caries and examine the previous restoration if it is good or needing repair or remake. If the crown lengthening indicated, in order to give sufficient length for making coping or to give a sufficient inter-arch space. In inter-arch space, as we said before, the determination of a case to be treated with overdenture should be done with care. Mounted models are extremely beneficial in determining whether there is an adequate space for the overdenture attachment or copings. As we said before, the inter-arch space required for every type of attachment. Then we'll start with clinical procedures. First, we do the abutment preparation. Here we do the crown reduction with or without endodontic treatment, and the periodontal treatment is also done in this phase. Second, we do the primary impression, alginate impression in stock tray. So we will talk about the preparing of abutment, crown reduction. Maximum reduction of the coronal portion is done. We will see that in pictures and the video. Crown root ratio is also important. It will decrease after the abutment preparation because we decrease the fourth arm. No interference with artificial tooth placement, restoration and polishing. This is the steps of crown reduction. Here, we will talk about planning of the preparation. Using a periodontal prop on the cast, we plan the height of the abutment we wanted to make, like this. Make a mark on the cast. Using a tapered stone with flat or rounded end, we can make our first bevel, like this. You must make give your patient a local anesthesia before you making that, because you will make an intended bulb exposure. Here, you will make the first bevel. The bevel is directed towards the labial or the buccal side, like this. Then we will eliminate all sharp areas in the preparation, like this, by using the tapered stone. Then we will make the final roundation using wheel stone or flame stone. Here, what we see, the bevel and the preparation we make. The shape of the dome-shaped abutments is like half an egg, like that. This is the labial part or the buccal part, and the most high part here is on the palatal or on the lingual side. Here we reach this shape by using flame stone like this, or by using wheel stone. So the first option, to close the canal here with amalgam plug, as we said. Then we are going to do the secondary impression. Most commonly made by using rubber base and pour it in stone like this. This is what we see here is a post that is inserted into the canal to taking the impression of the root canal. This is a coping impression. Clinical procedures. Here, we making our bevel, as you see. Then we can use Duralay to make a direct pattern inside the patient mouth. It takes a lot of chair time, but it will be a very accurate record to be casted directly inside in the lab directly without impression. But if you have your roots is not parallel to each other, you need to make an impression, because the lab here need to make the ball attachments or whatever you use, the type of attachment must be made parallel to each other to decrease the wear of the female portion, not to be changed fastly. This is after casting. So the options here in case like this, leave it as it is, or we can make an endodontic treatment and amalgam plug and taking support only from this option. Put a coping on it like this with a short dowel, or making an attachment. So when we take an impression to make the attachment, we need to make another impression to obtain the cast for and obtain the denture. So we may take an overall impression or all-in-one step impression to make the attachment and make the denture, or we may have two impressions in two steps. One impression for making the attachment and the other impression for making the denture. Our special tray could be made like open tray like this, or close the tray and spaced like this to give a space for the post that is used to register the impression of the root canal. This is a final impression, but without a post. Okay. If precision attachments are used, a special tray is used with either impression paste or elastomer, depending on the presence of undercut. The tray has a window over each of the abutments. This ensures any excess material flow out without displacing any of the tissues. The second step will be jaw relation record, like we made in complete denture, exactly. But we must ensure that the abutment teeth doesn't interfere with the proper support and proper vertical dimension we can make. The following step is try-in, also like complete denture. Fitting surface of the trial denture base should be relieved over the abutment for proper denture settling. Check for stability, check for vertical dimension, check for occlusion, and check for statics like we made in complete denture. Then we go for the denture processing, denture insertion, and post-insertion care like complete denture, the same steps, no difference between overdenture and complete denture in these steps. When we insert the denture inside the patient mouth, we have to sure about the passive contact of the overdenture with the alveolar ridge and with the abutment teeth. So we put a pressure indicating paste here is the fitting surface, as you see. If we have areas like this, the pressure indicating paste is totally displaced like this. This means the pressure area here in the on the ridge crust and the pressure area here onto the abutment tooth. We must eliminate all this pressure area by using or grinding them with acrylic tool. Then we apply a layer again of pressure indicating paste, and we must have this this shape. We have here an even layer of the pressure indicating paste, indicating that the denture is passively fit inside the patient mouth. Oral hygiene maintenance, the patient must be aware and educated about the oral hygiene maintenance and using special brushes like these in order to cleaning well around the attachments and the copings and under the bars. So brushing is very important, as we said, brushing of teeth, brushing of attachment. Also, denture care is also very important. The patient must clean his denture daily, and when there is a stains or a bad odor, he must return it to the lab in order to finish and polish it well. So we going to see some clinical cases. This is some of our clinical cases. Here, this is a single denture. Here we going to avoid the sequelae of combination syndrome. As you see, the patient is economically can't afford the fees for making attachments, so we decided here to maintain the remaining roots here in the anterior maxillary segment here. We do endodontic treatment and closed the remaining roots with amalgam plug. It's a very cheap option. Here we have, as you see, an irregular occlusal plane, and we have a natural teeth with a heavy magnitude of force. If we don't maintain these roots, these natural teeth will give a very high trauma to occlusal trauma to this area, making the bone resorb and hyperplasia will form it and making a papillary making flabby ridge here, and then the denture will start to move on the flabby tissue, making epilus fissuratum here and making a papillary hyperplasia and enlarged maxillary tuberosity, and this piece will over erupt and the pathogenesis will continue until the combination syndrome is totally formed. So if we maintain the support here by leaving these remaining roots under the denture, the patient feel like he is biting with his own teeth. The patient regulate his biting force. The patient also preserve the bone here around the abutment teeth. But we have a big problem here in this case. We have massive undercuts, as you see, all around the ridge in all dimensions. So we decide to use a thermoplastic polymethyl methacrylate in combination with the hard polymethyl methacrylate. The hard acrylic can be used in combination with the flexible acrylic to overcome most of these problems, as you see. This is the final impression of the case, and this is the final denture. We have a very huge arch. We have to put an 8 here, as you see, 7 and 8 here, in order to prevent the over eruption of the opposing teeth posteriorly. This is another case by using the precision attachment for ball and socket type. Here we make an upper complete overdenture. We make it palatless also to be smaller in size and to be more tolerable by our patients. This is the precision ball and the post, as you see. This will be roughened as this and then cemented by resin cement into the root canals, as we see here. Then we will use the denture by functional pickup technique, as we will see. We connect the male and the female portion by functional pickup technique inside the patient mouth. We instruct the patient to bite in center. Here, in this case, before we adjust it, you see when the ball size is not selected well, the lab may have a problem in setting of teeth. He set the canine like vampire here, as we see. So I have to eliminate this canine tip or decrease it to solve the problem. But here the selection of the ball size is we used a large ball. We had to use a small ball in this case. This is also a case of immediate overdenture. Here, the patient came by a partial denture and his teeth is like this. We make an endodontic treatment and make an immediate denture for the patient in order to manage this case temporarily. As you see, the immediate overdenture is a temporary procedure, not a final procedure or a definitive procedure. So we make it because we have an occasion and we have to make it fast in order to make a good or a more good appearance compared with his original natural teeth. Here, another case by preserving some remaining roots like this and making composite or glass ionomer plug here for them. Then we insert the denture above the roots, as you see. This is also a very interesting case. We face cases like this. We have teeth that have no mobility and have a good bone support, but it is not aligned well in the arch. Here we see the anterior teeth have a great tipping and the fanning anteriorly. Also, some of them are distal tapped or mesial draft. This is the photo before we work, and this is after we achieved the good statics in the final with the overdenture. Here we make a complete overdenture in the upper arch and partial overdenture in the lower arch. Let's go for the steps. First, we extract this lateral incisor because it will approximate with and as an abutment with the canine. So it is better to leave the canine alone as we made here. So we extract this canine. Sorry, we extract this lateral incisor and we make endodontic treatment for the both upper canines here and here, as we see here. We have also an over-erupted canine here that will interfere with setting of the teeth in the proper shape in the upper arch. So we make an endodontic treatment also for the lower canine here. Then we will cement the precision bowl and the post inside the root canals, as we see here. Then we make our primary impression. This is the secondary impression in condensation silicone. And here we make the final denture, upper complete overdenture and lower partial overdenture. As you see here, the upper complete overdenture here took retention from the bowl attachment, and here the partial overdenture here took its retention, as you see here, by flexible clasps, and only took support from the remaining root that is here. We left this remaining root to maintain the bone and to give the confidence for the patient, psychological confidence for the patient that it still have anterior teeth, and also give proper chewing efficiency and good biting force. This is a case also. This is a precision bowl and the post, like you see. We roughening it using a tapered stone. Then we are going to drill for the post. Then we use etching first. Then we, after etching, we do the dual cure, resin cement, and cure it with light cure. Like this, it will be like this. Okay, we are going to see another case of indirect post coping and attachment. Here we have 3 abutments like this. And this is the impression we took for the attachment assembly. We took an impression for the root canal, for the dome-shaped coping preparation, and the alveolar ridge surrounding it. Then we insert the plastic pattern of the bowl attachment in the cast like this, waxing up around it. Then when we need, as we see here, the bowl is not parallel to each other. It has several and different inclinations. This will wear, causing a severe wear to the female portion if we put them at this inclination. So we decide to remove the head of the balls like this, then inserting the balls with the this form is given from the company of attachments to be used with the surveyor. It will have a surveyor tool like this, putting them and luting them to the wax of the coping parallel to each other like this. So the balls here are parallel now to each other and also perpendicular to the path of insertion, parallel also to the path of insertion. We complete the waxing up around it. Here's a final shape of the preparation and the final shape of the waxed attachment assembly. Here is the post, the coping, and the ball attachment. Then we make a sprue like this for casting. Sprue former, attach the sprues to a sprue former like this. Then we cast this or these attachment assemblies into metal. Then we achieve finishing. This is the final attachments. Then polishing, then putting the female portion or the female cap here onto the bowl to ensure that the bowl is casted well, no dimensional changes occur. Some technicians sometimes make an over finishing and polishing, making the bowl is useless. So please don't cement the bowl inside the patient mouth until you're sure that it attached well with the cap, because it will be very difficult to remove it again from the abutment tooth. This is the final attachments. Here we are going to cement the bowl attachment here with copings. We use a resin cement for cementation it into the abutment teeth. And this is finally the metal housing, as you see here, that contains the female cap. And after that, we took the impression like this. Then we remove the excess from around the metal housing in order to give a space for stone to enter and register the height of the and the dimension of the metal housing over the coping. The cast after pouring will be like this. Here, the cause we took our impression by using the metal housing in order to give us an idea about the position of the attachment inside the patient mouth, so we can set the artificial teeth in relation to the height and the dimensions of the attachment without making the teeth more tipped anteriorly or more over erupted. It will give a bad aesthetics here. But if we planning for this, we can make a good aesthetics. We can also make a sufficient denture base over the attachment, so we avoid the breakage of the denture base above the attachment. Okay, this is a final denture. We finished it in the lab over the cast. Then we are going now to making the functional pickup. The functional makeup is made here. We use a plastic sheet or a foil sheet like this in order to prevent the self-cure acrylic resin from being in contact with the mucosa here, making a thermal or a chemical burn for the soft tissue of our patients. So we make this foil or this sheet of plastic between. We can use also a rubber dam sheet if you don't have it from your company. So you can use a rubber dam sheet between the male and the female parts to prevent the bad action of self-cure acrylic on the soft tissue here. And we must sure that the denture base is properly relieved and its passive fit on the denture foundation. We must have the same vertical dimensions, the same centric relation we made before. Then small amount of self-cure acrylic is put onto the relieved area on the fitting surface. Then we apply the patient to bite in centric. After the self-cure acrylic is totally set or cured, we removed the foil sheets here and remove also the excess self-cure acrylic from and around the denture base. It will be like this in the fitting surface. Now we can apply it into the patient mouth. Okay. This is the final shape. As you see, the patient will have fun with this denture that is give him a great value, great support, great retention, great stability with a smaller denture size. It will be a great experience for him. We have a video here. Let's see how we make the abutment preparation, dome-shaped coping preparation. We use a model to simulate this. Here we have a model with 2 canines. We need to reach this type of preparation we achieved here. This is the 2 types of burrs we used. We used a tapered burr like we see here. And we used also a flame stone to make the final roundation and reach the half egg shape. And here is the drills we used to make the post preparation. This is the initial drill we used to remove the gutta from the root canals. Then the final drill is used for making the drilling or making the space for the final post we'll use in impression, the green post here. Every system have a specific tools like we see here. We have the green drill here for green post like this. And we have the black drill for the black post. The color coding here to provide a post with the same shape of the drill. So if you make a drill with a black drill, you will put the black post. It will be snugly fitted into the root canal. You don't need to make any other impression for the root canal. Just putting the plastic post into the canal and that's it. Here we start by making the bevel. If we decide to make the coping height 3 mm, we make the bevel at 4 mm to give us a space, an extra guarantee that we don't reduce it so much. Here we start with bevel. The bevel is inclined towards the labial surface as we see. Here we make it more inclined to the labial surface. The cause that the level inclination is towards the labial surface to give a chance for the ridge lap of the artificial tooth to be set well over the abutment teeth without interference. Then we will use the flame stone here to eliminate all sharp angles of the preparation and to achieve what we said before, the half egg shape. No sharp angles. This is a very important issue in preparing these types of preparation. We don't have a finished line here. You have a knife edge bevel. We almost here reach the shape we are going to do, half egg shape. Bevel towards the labial. Then we are going to do root canal preparation for the post. Several systems can be used for these preparation. This is the initial drills to remove gutta-percha. In some systems, it will be gates, like gates Glidden drills to remove gutta-percha. And the final drills will match the size of the post that will be used in taking the impression. We must use the X-ray in this step to detect the length of the preparation and the length of the post. We must have at least 1/4 or 1/3 the apical seal is totally intact of the root canal. Then we insert the post after preparation. We insert the plastic impression post into the root canal like this. If it is not snugly fitted, we have to insert a light rubber base inside the root canal and then put the post in order that the post took the impression, the good impression of the root canal. It may be oval in shape, so the post will not be adapted inside it. So we have, in this case, to take the impression of the root canal. Then we start here with the initial drill to remove the gutta-percha. After we finalized our preparation, then we must be sure that the special tray is fitted well over the post and finally seated into the position. There is no interference with the post from the post with the special tray. Then we will apply light rubber base around the impression posts here and a medium rubber base inside the tray. Then we will apply the tray with a medium rubber base over the abutment teeth. This is all-in-one impression technique. We use here a double material in a one special tray. The impression will come like this. Maybe if you have a good tug back with the good retention of the post inside the root canals, you may have to remove it from the patient mouth and reinsert it into the impression again like this. Then you send your impression to the lab in order to making your attachments. Okay, we are now finished with our practical part. Thank you for listening, and I am very happy for this opportunity and this invitation from Dr. Sarah. And I promise you that we will meet again, inshallah. If you have any questions, I will be happy to answer it.
Thank you so much, Dr. Mahmoud, for this interesting webinar. It was very, very informative. So meanwhile, I will ask your permission to introduce our company to all the participants. And I request all the participants to kindly put their questions in the question and answer box if they have any.
Thanks, Dr. Sarah.
So this is our organization, DentistChannel.Online, Healthy Smiles, Wealthy Lives. I request all the participants to kindly save this number and send a message on WhatsApp with their name, so they will be added to our broadcast list and they will receive everything about our upcoming dental webinars and courses. Today's webinar is sponsored by NovaMind. NovaMind offers a full spectrum of implants and prosthetic solutions that accommodate any clinical need in modern implantology. We successfully supply highly demanded dental implant types called internal hex, tissue level, bone level, and active conical connection. Our EU production unit and product quality is appreciated worldwide. Dental implants and dental restorative solutions produced maintaining all the standards of EU medical device regulatory. Products are manufactured in Athens, Greece, and distributed worldwide with more than 1 million happy restorations. Those are the offers by NovaMind, and for more info, you can check their website. About our upcoming dental webinars, we have a webinar today at 5 p.m. Indian Standard Time about holistic dentistry with Dr. Linda Sutarjo. We have a webinar tomorrow at 5 p.m. Indian Standard Time about Botox and facial aesthetic medicine with Dr. Kanika. We have another webinar with Dr. Mahmoud Atiya tomorrow at 10 p.m. Indian Standard Time about space problem solving in fixed prosthodontics. On Friday, November 26, we have a webinar with Dr. Azhar Shuman about composite restoration and rubber dam isolation. On Saturday, November 27, we have a session with Advocate Sushant Samudrara about legal aspects of dental practice, Part 2. You can find Part 1 on our YouTube channel. About our upcoming dental workshops, we have a workshop today with Dr. Arushi about forensic odontology, batch 3. Another online masterclass with Dr. Mega, Be Like Dora the Dentist, finding and diagnosing the common oral lesions in daily clinical practice. And another online workshop with Dr. Prashant about basic suturing technique. If you have any question, kindly call or WhatsApp this number and visit our website, events.dentistchannel.online. If you're not a Prime member yet, kindly join our family to get free certificate of participation after every event and get exclusive discounts and special offers on our online dental courses, hands-on dental courses, and much more. Please don't forget to follow us on our social media platforms, Facebook, Instagram, YouTube, and Twitter. So now we can move on to the question and answer session. We have a question from Dr. Dharmendra. She's asking, metal bar can be used between two teeth?
Yes, we can use metal bar for splinting abutment teeth, as we can use it with implants. We can use it also between abutment teeth. We said in the first lecture we have two types of bar, but if we use only 2 teeth, we have to make a bar joint. What is a bar joint? As we said, it is a flexible or a bar that gives resilient movement between the denture base and the alveolar ridge. So the cross section of this bar must be rounded or half rounded or pear shaped, and give at least one movement, a vertical or hing movement, at least to be resilient, even if it will cause a cantilevering forces from the posterior part of the denture base.
Okay, Dr. Mahmoud, thank you. I think that's it for today. We don't have any other question. I would like to thank you again for sharing your knowledge and experience with us, and we are looking forward to organizing more webinars with you.
Inshallah.
Thank you so much, Doctor. Have a nice day.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum assalam.